All right. Hi, good morning. It's good to see everyone in this geriatric grand rounds before the holidays. We are very excited that today we have Michelle Fullard talking to us. We'll do a couple of announcements just about what's coming up next. We don't have grand rounds at the end of the month, but on January 8th is our next journal club, which will be led by Lee Derahi and Julia Bellantoni. And then on January 15th, our next grand round speaker is Samantha Farrow, who's going to talk to us about integrated behavioral health and geriatric primary care. We only have a couple of other announcements. Following today's grand rounds, you'll get an email with the recording, a copy of the PowerPoint, an email to an online evaluation if you don't fill out a paper copy here and you're joining us online. And then please submit questions in the chat or the Q&A box. It is being monitored. We'll use that to facilitate questions for our virtual attendees. So then without further ado, we have Michelle Fullard. She's an associate professor of neurology here at the University of Colorado. She serves as the director of clinical research for the Movement Disorders Division, and she's also the director of the Parkinson Foundation Center of Excellence. She got her undergraduate and her medical degrees from Vanderbilt University, and she did her neurology residency at the University of Virginia, and then fellowship training in the University of Pennsylvania in movement disorders. While she was at Penn, she completed a Master's of Science in Clinical Epidemiology, and now she focuses on decision-making for individuals with Parkinson's disease, and she wants to develop and implement tools that support informed value-based decisions. She's supported by K76 Beeson, and she is going to adapt a deep brain stimulation surgery decision aid to better fit the needs of patients with cognitive impairment. Come on up.
All right. Well, thank you, everyone, and thank you for having me. So I'm Michelle Fullard. I'm a movement disorder neurologist here. I also managed to break my foot a few weeks ago, so if you might see me kind of shrink down and sit, just warning you, I'm just sitting. But I'll be talking about my work on improving shared decision-making for patients with Parkinson's. And currently, the tools that I'm developing and adapting are around the decision for deep brain stimulation surgery. So no industry disclosures. This is just a list of some of my funding. Some of the research that I'll be talking about was funded by a Prior Birch K-12, Lauren G. Moore Faculty Launch Fund, and the Davis Finney Foundation. So before diving into the development of the tools that we're making, I just wanted to briefly talk about Parkinson's disease progression, how we think about medication adjustments, and at what time point in there we're thinking about DBS and advanced therapies, because that's where we're planning to implement these tools. Then I'll talk about how we developed these shared decision-making tools, and then now how we're adapting them for patients with cognitive impairment. And while this is specifically for patients with Parkinson's, I'm hoping that the adaptations that we're making can be applicable to a lot of tools. Because obviously, mild cognitive impairment is pretty common. You guys, okay, sure. Mild cognitive impairment is very common, and there are really no tools addressing the cognitive weaknesses that can affect decision-making. So that's what we're trying to do. So to begin with, I just want to start with a case that you can think about as we're talking about medication adjustments, advanced therapies. So imagine you're seeing a 73-year-old woman in clinic. She was diagnosed with Parkinson's 8 years ago after developing a right hand rest tremor. She has slowness, stiffness. Levodopa in the beginning provided marked improvement in mobility and function. But then over the last 2 years, she's been reporting increasing wearing off before her next dose, even up to an hour. She's now taking levodopa every 3 hours. She has peak dose dyskinesia, and I'll show you that. And she really has to plan her day around her medication schedule. And she may avoid going out at times when she thinks she'll be off. She has some mild cognitive concerns, some word finding difficulty, slower processing speed. Her MoCA was a 24 out of 30, and some mild orthostasis. So just think about, what are the treatment options to reduce off time and improve function for this patient? And we'll come back to her in a little bit. So I know you all already know this, but just wanted to start out with what is Parkinson's? Well, we all know it's a neurodegenerative disease caused by the loss of dopamine neurons. A lot of other neurotransmitters are involved, but dopamine is one of the main ones. Loss of dopamine neurons occur in the substantia nigra, causes symptoms of tremor, rigidity, bradykinesia, and there's obviously continued loss over time, and that will change how medications are working and the adjustments that we need to make. To have a clinically established diagnosis of Parkinson's, you have to have bradykinesia. So that is a core feature. And so that is not only just slowness of movement, but the strict definition is a decrement in movement as well. So that means we're having them do the finger taps, movements are getting smaller and slower over time as well. So they have to have that, and then either rigidity or that rest tremor. In addition, according to MDS, they cannot have any of these absolute exclusion criteria, can't have any of the red flags, and then have to have at least 2 of the supportive criteria, which include things like a clear and dramatic response to levodopa. And then who gets Parkinson's? So age is the biggest risk factor for Parkinson's. Overall lifetime risk is about 2%. By 65, it's 3%. By 85, it's 5%. And it affects about 1 million in the US. Every year in the US, about 90,000 people are diagnosed. So while we don't think of it as very common, it's not uncommon. And 90,000 would fill the Rose Bowl Stadium. It is more common in males, but not as much as we would think. So our old estimate was that it was 1.5 times higher in males, the incidence. Newer research has come out in the last few years, some meta-analyses and systematic reviews, showing that's really maybe about 1.2 times higher in males. In some populations, it's 50-50. So Japan, Korea, we're seeing more of an even split. So there may not actually be a difference in sex as far as incidence and prevalence. It might actually be more our ascertainment, like who's actually seeking care. There's bias, all kinds of things will play into that. But while, if you Google Parkinson's, you will see a bunch of older white men, but that is not the case. Don't think of Parkinson's as that. All right, so we have all these people with Parkinson's. Who's actually seeing them? Well, movement disorder specialists are seeing a minority of these patients. We only see about 9%. About half will see a general neurologist, and almost 30% will see a primary care physician. So it's important that it's not just us who know how to take care of Parkinson's, and I know you see a lot of Parkinson's and you know how to take care of these patients as well. So I'll briefly go through how we think about medications and then how we think about making changes, and again, where DBS and our decision support tool fits in there. So if you see a patient, you think they have Parkinson's disease, you don't have to start medication right away. The big question is, do they have functional impairment, or do they have symptoms that are affecting quality of life? I may have a patient who's very functional, but their tremor is really embarrassing them. It's stopping them from going out. So then we may start medication there. But let's say they're not bothered by their symptoms, no functional impairment, then we're really encouraging exercise. That's the one thing that can actually slow progression. And the other thing, if we don't think they're going to start medications in the next 6 months, we have a lot of neuroprotective trials here and obviously elsewhere in the US that really, most of them will require patients to be medication naive. So if you see a patient, you diagnose them with Parkinson's, you don't think they need medication, send any of us in the group an email, Epic message. We're happy to connect them to clinical trials if they're interested. But then let's say they do have functional impairment, they want to start a medication. That's when we'll talk about what the options are. There has been this thought in the past and a movement in the movement field to first it was away from levodopa because there was this thought that it could be neurotoxic. If you start it early, you're going to get dyskinesias and motor fluctuations early. Now there's been a move back, and we know that that's not actually the case. You don't need to wait and save levodopa for later. You don't build up a tolerance to it. And that patient's quality of life really is better on levodopa. So it really is the gold standard. But there are other options, and we don't necessarily always start levodopa first. So if the patient's symptoms are pretty mild, you might start an MAO-B inhibitor, but just letting them know this is going to be very mild symptomatic benefit. Dopamine agonists have really fallen out of favor just because of the side effect profile, but there are certain cases where we might use them. But if you look over on the right, dopamine agonists more likely to cause edema, somnolence, sleep attacks, impulse control disorders are ones you really have to warn patients about. I've seen marriages fall apart because of them, people go to jail, and the person who it's happening to is not always aware. So then it's important that family and other care partners are aware. Hallucinations are more common, nausea more common in dopamine agonists. However, there is a place for them. If you have a younger patient, they're still working, they don't want to take levodopa 3 times a day, there are XL versions of dopamine agonists that they could take, and then you just want to monitor for those side effects. But then levodopa, again, is that gold standard. It's going to be the most effective medication for Parkinson's. So I'll briefly go through some of these medications and then we'll get more to the shared decision-making. But levodopa, again, preferred especially for older adults, better tolerated. With any of these, we're going to start low, titrate slowly, and it is available now in more and more different formulations, so we have a lot more control over it. Main side effects are going to be nausea, orthostatic hypotension, hallucinations, and then we'll get into the fluctuations and dyskinesia. And then this terminology is something we talk with all of our patients about because we are going to adjust medications based on their description of their symptoms and what's happening. So off time is when Parkinson's symptoms are returning. So carbidopa-levodopa is the effects are wearing off. And this can be predictable, like our patient about the hour before their next dose is due, they're starting to wear off, tremors coming back, slowness and stiffness is coming back. As Parkinson's progresses, it can become unpredictable and they can just suddenly be off. And that can cause a lot of disruption in function and quality of life. And then on time is when Parkinson's symptoms are improved. So the medication is working well. And then motor fluctuations just describes that alternating periods of off and on time. And then in addition to this, a lot of people will have dyskinesia. So those will be the extra wiggly movements. If you've seen Michael J. Fox give an interview recently, it's kind of these flowing dance-like movements. It is due to dyskinesia, but it's due to levodopa, but people without Parkinson's disease, if they were on levodopa, they wouldn't get dyskinesia. It's typically occurring at the peak dose. And I'll show you a video here. So you can kind of see the head, truncal, neck movements. It's involuntary, and again, usually happening at peak dose. And so if we look at the progression of Parkinson's symptoms, early on, you still have enough dopamine neurons that you get a pretty consistent response in the levodopa. You're not noticing these ups and downs. Then as we get closer to mid-stage, you're starting to notice some of these wearing off symptoms. And then by mid-stage, you have a lot more of the defined off and on, maybe peak dose dyskinesia. And so this is really where we're thinking about advanced therapies. And this is where we will be implementing our decision aid. When we get to more of the late stage or advanced, that's where you have a lot of more levodopa non-responsive symptoms. So more postural instability, freezing of gait, where feet are stuck to the floor, they can't get them moving, worsening dysphagia, worsening cognitive impairment. And so there you're unlikely to get enough benefit from the advanced therapies to warrant the risk. And so I've briefly mentioned this before, but there is a change in medication response over time, and that is due to the continued loss of dopamine neurons. So again, in the beginning, you see the blood levels of levodopa. Usually you're within the therapeutic window. And so that is this, I don't know if you can see my mouse, but it's the pink, the middle part there is the therapeutic window. That therapeutic window will narrow over time so that then in the green part, you can get that peak dose dyskinesia. And then in the bottom blue part, you're getting more of that off time. So as you advance, you have less dopamine neurons to kind of buffer the amount of dopamine, and you're more dependent on the state or the blood levels of levodopa. So as we're seeing the narrowing of the therapeutic window, our goal is to really keep the fluctuations in blood levels within that therapeutic window. And so that's where we'll talk about how do we do that with advanced therapies or other medication adjustments. So when we think about motor fluctuations, if we're treating off time, depending, how much off time they have, if they also have dyskinesia, some of the strategies are first, you can shorten the dosing interval. If they're always wearing off 30 minutes before their next dose, we'll just shorten the time interval. Sometimes you can increase the dose and that will give you more on time. However, that does risk dyskinesia or worsening dyskinesia if they already have some. For milder fluctuations, you can add an MAO-B inhibitor. You can also add a COMT inhibitor. If you're adding Comtan, you just have to warn them it can discolor their urine so they don't think it's blood. There's also a new medication on Gentis that is a once daily COMT inhibitor. Istradefylline is a newer medication. It's an adenosine A2A receptor antagonist. Again, we'll just give you a little bit more on time. So someone who's having milder fluctuations, it could be beneficial for. And then I'll talk about some newer extended release levodopa versions that have come out. And then for dyskinesia, there's not a lot of direct treatment for that. So amantadine is one, but we really have to use that with caution because it can have a lot of side effects. You can see over on the right, that's the livedo reticularis. It can cause edema, can also cause confusion, worsening cognitive impairment, and contribute to hallucinations. If you do have dyskinesia, one potential strategy is to lower each dose and then have more frequent dosing so you're not having that peak above the therapeutic window. All right, so I'll briefly talk about some newer medications, some alternate drug delivery systems, just so you're aware of some that have been approved just in the last few years. So the same company makes these two medications. They're extended release versions of carbidopa-levodopa. The one that was just approved last year is Crexont. And in the phase 3 trial, it showed 30 minutes more on time, which you might think, well, that's not that much. But they were able to change dosing to 3 times a day compared to 5 for regular carbidopa-levodopa. So that can be a big deal for patients. The older, similar-ish mechanism is Rytary. That was approved in 2015, hopefully going generic soon, so it'll be a lot cheaper. That showed 1.2 hours more on time, but it was dosed a little bit more frequently, closer to 4 times a day, compared to the immediate release that was 5 times a day. And the Crexont, it comes in capsules, but it's these little pellets that adhere to the small intestine, which is where carbidopa-levodopa is absorbed. And you can't open those capsules. And then they just slowly disintegrate over time. Rytary, on the other hand, is made up of these beads. So a third of them are immediate release, so you'll get some benefit right away. 2/3 are extended release. That capsule you can actually open up. So for patients with dysphagia, you can open it up onto applesauce so that they can still get the benefit of an extended release medication. And then there are also rescue medications for Parkinson's, and these are good for those sudden offs or unpredictable offs. So one is inhaled levodopa, and this is it's a powder. So you're putting a capsule in this device, crushing it so that powder is now available to inhale. A lot of patients don't like that, and it can cause a lot of coughing. It can also cause discoloration of the sputum, like a black color, so we always have to warn them of that. But there is some improvement in tolerance if people drink a glass of water beforehand, wets the throats. They're not having as much coughing after they use it. I've had a lot of patients try it. I've had some stay on it. It is useful to have something that can kick in pretty quickly. So it takes about 10 minutes, might kick in a little bit before, lasts up to an hour. It's not going to be your main medication, but again, can be more of a rescue if you're having those sudden offs. And then something that was used probably more frequently in the past is subcutaneous apomorphine, also known as Apokyn. Again, very good for those sudden or unpredictable offs. This is a subcutaneous injection, and the onset is within 5 to 10 minutes. This is a dopamine agonist, though, and can have a lot of nausea associated with it. We used to use Tygan, but that's not really available anymore. You can't use Zofran because that can cause a severe hypotension. We can't use dopamine antagonists because you're going to make Parkinson's symptoms worse. So when Tygan was no longer available, the company said, oh, just give them ginger chews. Not exactly helpful, but what we find is that if we start low and just titrate very slowly, a lot of people do tolerate it without the antiemetic. All right, so now I'll get into the advanced therapies, and this is, again, where we're thinking about implementing these decision support tools. So when should we be thinking about these advanced therapies, especially something like deep brain stimulation surgery? So one is when we're seeing a lot of these motor fluctuations or dyskinesia despite optimizing medications. And patients are usually taking at least 4 or more doses of medication per day. And you can be limited by side effects as far as further escalation. So you can't further optimize because of their side effects. So one that has been out since about 2015 is this enteral suspension of carbidopa-levodopa. It's this gel form. It does require a PEG tube, but one of the benefits is it bypasses the stomach, so it's a J-arm. So a lot of patients with Parkinson's have delayed gastric emptying, so you're bypassing that. Provides continuous dopamine stimulation throughout the day. Because it's going directly where it's absorbed, we're often able to decrease the total amount, and it decreases off time. Downsides, mainly around having a PEG tube. There are a lot of complications with that. It can get clogged, they can come out. We do see higher incidence of peripheral neuropathy with these, so about 1 to 3%. More common in those who already had a lower B12 level. So we usually recommend B12 supplementation for any of our patients on levodopa because B12 is involved in the breakdown of levodopa. So likely at least some contribution from functionally lower B12 levels. And then, of course, you're having to manage a device. So what is newer and was just approved last year is something called Vyalev, or this is a subcutaneous carbidopa-levodopa infusion. And it's a liquid prodrug, and it's a relatively large pump, so people will be hooked up to this pump 24 hours a day, but it increases on time by almost 2 hours, really decreases those ups and downs and those fluctuations. And it's a little cannula, so you can see in the top picture, it looks like a sticker or Band-Aid they put on. It has a tiny little cannula that goes right under the skin, and then tubing that connects to the pump, and then they're getting 24 hours of usually a lower dose of carbidopa levodopa. With this in the clinical trials and just clinically what we've seen, a lot of people get nodules, so you have to really rotate where you're putting it. And usually those will go away with time, but then you can run out of space where to put it, because we usually recommend in the beginning changing the cannula site every day. You might be able to go to every 2 days, as long as you're not getting cellulitis. But cellulitis is a potential complication of this therapy. And they do have to learn how to manage this as well. They have to be able to properly place the cannula. They have to be able to hook up the tubing. And you can imagine for someone with Parkinson's who already has fine motor impairment, that can be difficult. So we usually want to make sure if they're having trouble with that they have a care partner who can assist. And then this was actually just approved in the US earlier this year. It's been approved in other countries a lot longer. I'd say I don't think anyone in our group has used this yet, but it's subcutaneous apomorphine. So that's a dopamine agonist and provides 24-hour subcutaneous infusion of this apomorphine, very similar to Vyalev. It reduced off time by about 2 hours in trials, but patients still needed to take levodopa. So it's not replacing all of their oral medications. Vyalev typically can. So in this trial, patients on average were taking 1,500 milligrams of levodopa equivalents. They were only able to reduce by about 500. This one can also have infusion site nodules, maybe a little bit less than the levodopa. You can get nausea with this, sleepiness, and then hypotension was a big one as well. And then coming to deep brain stimulation surgery. So this was FDA approved in 2002. Here, we're often placing electrodes in the STN or the subthalamic nucleus unless there's a reason to go for the GPI. Important things that we tell our patients, because there are a lot of misconceptions out there, it does not slow disease progression. The disease will continue to progress at the same rate, but because it treats symptoms a lot better than medications in some ways, patients will often say, I feel like I went back in time 5 years. So they will feel much better, but it is not affecting disease progression. Another big thing for patients is this is not a therapy of last resort. So again, we're thinking more that mid-stage when they're having a lot more fluctuations that we just can't get rid of with medication. It improves on time, can decrease dyskinesia, and if we're going for the STN, we can often decrease medications by about 50%, which then means we're able to reduce side effects associated with those medications. And then it's also important with patients to go over expectations. What can DBS treat? What does it not treat? We've talked mainly about the motor symptoms of Parkinson's. As you all know, there's a whole host of non-motor symptoms associated with Parkinson's. It's not going to treat most of those. So it will improve bradykinesia, rigidity, tremor, improves off time, can decrease dyskinesia. It is not going to improve balance. It is not going to improve cognitive impairment and can actually make it worse. So it's really important to make sure you know what the patients expect and then let them know whether or not DBS can treat that. And then can't be a movement disorder specialist without showing videos. So I wanted to show you a patient who has Parkinson's, who has DBS. This video is a patient off stimulation, so you can see a pretty severe rest tremor. And then here, right side is very well treated. Left side, you still have some baseline tremor left. All right, so briefly, who is a good candidate for DBS surgery? So like we talked about, people with motor fluctuations, medication refractory tremor is another indication. And then a smaller group are those patients who we just can't give them enough medication to control symptoms because of intolerance to medication or a lot of side effects. And we have to make sure they have a clear diagnosis of Parkinson's, that they are responsive to levodopa. And again, dementia is exclusionary, but a lot of people with mild cognitive impairment do end up undergoing DBS. All right, so we'll briefly come back to our case. So if you remember, she was taking carbidopa levodopa every 3 hours. She was having dyskinesia. And these are all the things we talked about as far as potential treatments of motor fluctuations. She's already taken it every 3 hours. We probably can't shorten the time interval. We probably can't increase the dose because we'll worsen dyskinesia. Probably earlier on in her progression, she tried some of these adjunctive medications. So probably at this point, we're either adding one of those extended release carbidopa-levodopa medications, or she would be a good candidate potentially for an advanced therapy. All right, so I'll move into now what we're doing to create decision support tools for DBS and helping patients decide who are in that area of candidacy or like mid-stage of Parkinson's, potentially make a decision about going forward with DBS. So we all know that shared decision-making is important. We don't always have time to do it in our clinical encounters. And I would say we find it hard when people are coming in interested in DBS. We spend so much time just educating about what it is. And then it's really hard to get to the part where we talk about what are your preferences? What are your values? How does that fit with DBS? And that's where we think a decision support tool can be helpful. And DBS is an elective brain surgery. It is a big deal. So it's not like we think you're a candidate, so you have to go for it. It's not right for everybody, and it really is a preference and value sensitive intervention. And now we have more and more options for people who are in this mid stage, and they all have trade-offs. So again, it will depend on patient preferences and expectations, and we really need to elicit those. And there have been multiple studies in Parkinson's looking at decision satisfaction and satisfaction with DBS and what the predictors were. And what they found is that expectations were a really big predictor. So you could have two patients with the exact same great motor outcome. And if one expected improvement in tremor and slowness, they think it's great. They're very satisfied. The other patient thought they were going to be able to socialize more, thought cognitive impairment would get better. They are not at all satisfied, even though you look at them and they look great. So again, really important to elicit those expectations. And then we also have multiple studies showing that Parkinson's patients in general do want to be very involved in decision making, but they often are not fully informed of all the options. And oftentimes this is a function of they're seeing a neurologist who only does DBS. They're not hearing about the other infusion therapies, or maybe they only do infusion therapy, so they're not hearing much about DBS. So we want to have a tool that can lay out all the options for them. So what originally got me into this space was actually my prior research looking at gender disparities in Parkinson's disease care. And what we originally looked at was who was getting DBS. And we found that women receive it much less common than men, or much less often. But what I showed you is that it's not because men are more likely to get Parkinson's. There's not actually that much of a difference in incidence and prevalence. And so we wanted to look at other potential reasons for this disparity. And what research has also shown is that women receive equal or maybe even greater benefit from DBS for their Parkinson's compared to men. So that also shouldn't be a driving factor in this. So in one of our studies, we used HCUP data to look at all of the DBS surgeries across the US from 2011 to 2017 and looked at the proportion of men and women getting DBS. Or the proportion of those getting DBS who are men and women. And what we found was that pretty much across all of these years, only about 30% of those getting DBS were women, and it wasn't changing. And if you look at other data before 2011 and since then, it really, again, isn't changing, which shouldn't be that surprising because we really haven't done anything to try to make it better. So some of the things that we were interested in as factors that could contribute to lower use, women in general with chronic disease have less social support. They tend to have more caregiving responsibilities, less access to specialty care, fewer referrals, takes longer for them to get in. And then what I found really interesting were gender differences in shared decision-making. So this was informed some by Parkinson's literature, but mostly surgical therapies outside of Parkinson's, was that women tend to be less informed about surgery as a treatment option. And I'll show you a study looking at that. And they tend to exhibit higher decisional conflict than men. And in a lot of studies, or even just clinically, they're more likely to decline procedures, but not necessarily because of risk aversion, but because they need more information before they can make that decision. So we thought all of this in the literature was pointing towards women's decisional needs were not being met effectively. And this was a study that I always find so interesting looking at physician bias. I don't think we could do this in Parkinson's, but this was looking at total knee arthroplasty. This was a group in Ontario, and they had two standardized patients. They had the exact same x-rays, exact same symptoms, and they went to 71 surgeons and family medicine physicians. They had this script that they were supposed to follow as far as presenting what their symptoms were. And what they found was that the surgeon recommended total knee arthroplasty to the male patient 22 times more often than the female, even though their symptoms were exactly the same. And then in a follow-up study, they had a care partner with them, and they were taking notes on everything that was happening in the visit. And they found that there were a lot fewer shared decision-making elements in the visits as well. So the women were less likely to hear that they had a role to play in the decision-making. There was less discussion about the pros and cons of a surgery, the uncertainty, assessing their understanding. The one thing that was higher in women was a discussion of alternative therapies to surgery. So again, I wish we could do something like this in Parkinson's. I think it would be a little too complicated, but I think it just shows there's a lot of implicit bias because the same group also sent out a survey to all of these same physicians and said, do you consider gender when referring for surgery? And of course, everyone said no. So, it's probably more implicit than explicit bias. And as part of our needs assessment for a DBS decision aid, and again, mainly around the gender disparity in the use of DBS, we looked at decisional conflict. And so this is personal uncertainty about which option to choose, and you can measure it using the decisional conflict scale. So we evaluated decisional conflict in 57 patients with Parkinson's who are just starting the evaluation process for DBS. So they're considering DBS, we put them through the ringer, and then they're deciding if they want to undergo DBS or not. Similar to a lot of Parkinson's populations, this was mostly a white male cohort, highly educated, so not necessarily representative of all those in the community. But what we did find is that decisional conflict was very high. So on the decisional conflict scale, scores greater than 37.5 are associated with decision delay, feeling unsure about the decision, and then scores less than 25 are associated with implementing those decisions. And you can see for our Parkinson's patients, the total score was 35, so very close to that 37. The uncertainty subscore was 45, and informed was 39. So they're feeling very unsure, they're feeling uninformed. What was interesting was underneath, you'll see decisional readiness. Many felt moderately ready or ready to make a decision, but it seems like they were just still feeling uncertain about it. So this did seem like an area we could help patients with a decisional support tool. So that brings us to decision aids. So we decided to create a decision aid, and I'll actually credit Hillary Lum with this. I was in Clinical Faculty Scholars, and I was trying to figure out, what is my intervention going to be? And she said, why not make a decision aid? So kind of changed the trajectory of my career. But a decision aid is a tool that helps patients understand the options and consider their values. So that's what makes it really different from just an educational document. So they're considering their values as they're weighing the risks and benefits. And it does encourage active participation in decision-making. A Cochrane review and a lot of other studies have shown that decision aids improve knowledge, they lead to more realistic expectations, lower decisional conflict, and we've already shown that that's high in our patients, and improve that concordance between values and choice. So as we were developing our DBS decision aid, we were guided by the Ottawa Decision Support Framework. And the core premise of this framework is that there are decisional needs that, if unmet, lead to poor quality decisions. So under decisional needs, what you want to address is decisional conflict, inadequate knowledge, unrealistic expectations, which again is really important for DBS, unclear values, and then making sure they have the support and resources they need. Under the decisional support over at the bottom, you can see that clinical counseling, decision tools, decision coaching are all potential interventions. And so we decided to develop a decision tool. And if you do it appropriately and correctly, and you can address all these decisional needs, then that can lead to a better quality decision. And that's a decision that's informed and value-based. And you want to show that you're actually reducing decisional needs, reducing decisional conflict, and then longer term, depending what the decision is, are they continuing to implement that decision? It may actually reduce inappropriate healthcare utilization over time. So it can have some longer term effects as well. So to develop our DBS decision aid, we started with interviews of 33 patients with Parkinson's, really just to better understand how they're making the decision, what goes into it, what are their decisional needs. So this included 16 women, 17 men, and these were patients who had been evaluated for DBS in the last 3 years. And still, we were looking at gender disparities. So we wanted to know, are there any gender-based decisional and informational needs? How can we better address women's decisional and informational needs? So in this study, we came up with 4 themes. What we found that information sources were pretty similar for men and women, but what we found is women specifically wanted to talk with other women with DBS just to hear what it was like, specifically around how much of their hair was shaved to, what it was like to be in the halo, how much support they would need afterwards. But they had a really hard time finding these women because when they're in their support groups, it's the men who have DBS. And then the reasons patients decided to have surgery were varied and often very personal. Many mentioned they wanted that improvement in motor symptoms. Most of the women also mentioned not wanting to be a burden on their family, wanting to be able to spend more time with their family and their grandkids. Whereas more of the men, there were some who mentioned that, but they were more focused on motor outcomes. Doesn't mean they weren't thinking it, but what didn't come out in the interviews. And then we also found that the decision-making process occurred over time, sometimes years. So patients often said, you know what, my doctor mentioned it a few years ago, but I said, absolutely not. I'm not undergoing any kind of brain surgery. But then as symptoms progress, many said, I didn't really see any other options. I felt like, my function is declining, my quality of life is declining. Now I think maybe the risks are worth the benefits. And what we found is that throughout this process, women just described a lack of support through decision-making and through the surgery and post-surgery. In our cohort, and very similar to a lot of Parkinson's cohorts, many of the women were either widowed, divorced, much less likely to have a spouse or partner at home, whereas many of the men that we interviewed did have a spouse. And if we asked, are you at all concerned about support? Oh, no, my wife will take me to the surgery and the programming appointments. So it wasn't even something that they were concerned about. What I found interesting was we had one woman in the study who had great support from her husband, from family and friends, but she was so worried about how to support her husband supporting her. So it's interesting how people are approaching this and thinking about it. And then lastly, we found, which is common, that surgery concerns were often tempered by relationships with the team. So if they trusted the team, they felt that they were in good hands, they often felt like they could move forward with the decision. Women, though, did have a little bit more trouble balancing risks and benefits and thinking about how the risk might apply to them. Many said, I'm just not going to think about it. I'm going to assume it's not going to happen to me, or my surgical team won't let it happen to me. And then that's how they moved forward. And so one thing we're trying to do as we adapt our decision aid is figure out how to better show the potential trade-offs and risks and benefits so that women can better conceptualize how that applies to them. So then after we did those interviews, we drafted an initial decision aid using what we learned from the interviews and then best evidence from the literature, and then underwent alpha testing. So that's where we brought 4 patients in. They viewed our drafted the decision aid, gave us a lot of feedback. We implemented those changes and then took it back to another group of 4. We did that until no new feedback was, or until we got no new feedback. And so we did that with a total of 16 patients, and it was 4 rounds. After that, the decision aid was reviewed by experts in movement disorders, functional neurosurgery, and experts in shared decision-making. And then we made our final changes, and then we had our paper version of a decision aid, and that underwent a small pilot trial. Since then, I received another grant that allowed us to adapt this to a website version, because throughout the process, a lot of patients were saying, it'd be really nice if I could just pull it up on my phone, or if I could send it to other family members. So we were able to make this website, and you can see up across the top all the different sections, and that was informed by what patients told us they really wanted to know. And then there's an interactive section that I'll show you that really helps with expectation management. There's a values worksheet. So again, to really make sure this is a value-based decision. And then as part of this whole project, we also implemented an ambassador program. And that's where we match up patients who are considering DBS with those who have already undergone DBS, so they can learn more about what is it actually like as a patient to be awake during surgery, or what was the programming like. And we did that especially for women who are having so much trouble finding those other women with DBS. So this is just a few of those pages from the decision aid. Over on the left side are the interactive sections. So the patient will click on any symptoms that they're experiencing. So if they click on shaking, it'll pop up with how much we expect shaking to improve. And so this is based on meta-analyses and the best evidence from the literature. So it'll be a range and it'll be averages, but they can expect somewhat some improvement around that. And then if they click on some that don't improve, it will tell them that. So they'll be aware of which of their symptoms won't improve. Once they click on everything that they experience, they can then get this personalized symptom report that they can print out. So they can really see exactly what will improve for me, by how much, and what won't. And does that fit with what I need? Maybe I have tremor that doesn't bother me, but it's balance trouble that really bothers me. Well, maybe DBS isn't the best for me. And then over on the right side is just a depiction of the risks of DBS surgery, which overall are pretty low, but just making patients aware what could happen. And if it were to happen, then what do you do if you experience one of these events, just so they know what to expect. And then informed by women with Parkinson's, we added in the support. So again, a lot of the women who were more alone in the decision-making process, we just wanted to let them know, based on what other women had told us, what do they need at each stage. So they can talk to family, friends, even home health after getting surgery to make sure they have everything they need so they can feel confident moving forward with the decision if it's the right thing for them. And then over on the right side is just part of our values clarification, which is something that we're continuing to improve. But again, just getting people to put down what symptoms bother them the most. And then they can look at, which column is that in? Is that in the won't improve with DBS? Again, then maybe DBS won't be the best for them. And then we ask them, what symptoms must improve for you to consider DBS successful? So that really makes them think, what is my, maybe I'm not saying what my hope is for DBS, but we're just trying to elicit that to, again, make sure that they feel confident moving forward and that their expectations are realistic. So once we had created this website, we then did some acceptability testing, which is part of the IPDAS criteria or the International Patient Decision Aids standards. And so we had patients with and without Parkinson's disease view our decision aid and then do the Ottawa acceptability questionnaire. And this is looking at things like the length of the decision aid, the amount of information, how balanced it is, and if they think it's suitable for decision making. So we had 46 participants who took part in this study. And what we found is, for the most part, it was very acceptable. Language was easy to follow. It was the right amount of information. About 70% thought it was well balanced, but the other 30% thought it was more slanted towards DBS, which this is more DBS versus we're not going through all the other options. We just show them what they are so they can find more information. So not too surprised, but something that we'll continue to work on and assess bias in the future. And then when we asked, would this have been helpful when deciding to get DBS? So 78% said yes. So we were a little surprised. We thought this would be helpful. Most of the rest were neutral. When we looked at that group that was neutral, it was people who had a disease duration of only a few years, had not undergone DBS. And so we think they probably weren't in the space where they're actually thinking about this at the current time. So it wouldn't be as useful for them, but more for those who are actually having fluctuations. And then most would recommend it to others and were pretty satisfied with the quality. And two of the questions as part of this acceptability questionnaire are open-ended questions. And so it's, what did you like or not like about the decision aid? And do you have any other feedback? And the information we got back really fell into 4 categories. And so people commented that they thought it had a lot of the information they needed to make the decision. At least there, people thought it was well balanced. They didn't think there was a lot of jargon, that it was easy to understand and easy to navigate. And then this decision aid is currently in a pilot trial. It's a bit of a complicated one, but we are randomizing people to either use the decision aid right away, and we were going to randomize it to no decision aid, but then clinicians, patients were all worried about people not getting access to it. So now we're randomizing people to immediate decision aid versus delayed decision aid. So we at least have some time points where there's a group who hasn't received it yet. And people, if they are immediately getting the decision aid, they'll get it right as they're starting the evaluation process. We have surveys and interviews throughout the evaluation process just to learn more. How are people approaching this decision? How are they making it? How are they using the decision aid? Are they not using it? So we can improve it for further iterations and improve the implementation of the decision aid. And then one of our bigger visits is after they've made a decision about whether or not to undergo DBS. And then 3 months later, we'll look again at decisional conflict and just their satisfaction with the decision. As I was going through this whole process, again, really focused on gender disparities, what I found was that more and more of my patients with mild cognitive impairment were having problems making this decision. And it might end up being 4 or 5 visits before they could even decide to actually move forward with the evaluation process. And not because they didn't want to, they just had a lot of trouble kind of weighing the risks and benefits of it. So that's where my current grant, the BSIN K76, is looking at how does cognitive impairment affect decision making? And then how can we incorporate changes into our decision aid or adaptations to better support people with cognitive impairment? So one reason we decided to look at this in our population, mild cognitive impairment is very common in Parkinson's. So at the time of diagnosis, up to 27% will already meet criteria for mild cognitive impairment, or MCI. And then looking at studies across the US, those who are starting the evaluation process, up to 80% will have single or multi-domain MCI at the time of DBS evaluation. So it's very common. We often think of cognitive impairment as exclusionary. That's more dementia. MCI, we can still do DBS. And then it's more than just how cognitive impairment affects decision-making, but DBS can also worsen cognitive impairment and cause more cognitive decline. So then that's something else that they're having to weigh as well, that maybe it'll help my motor symptoms, but then I might see more cognitive impairment afterwards. So what we're looking at are the domains of that are typically affected when patients with Parkinson's have cognitive impairment, which is often executive function, attention, working memory, verbal fluency, processing speed, visuospatial, and how that affects capacity to make decisions. Most of the studies that have looked at this have looked at just capacity in general to make a decision. So do they understand the decision? Do they appreciate the risk? Are they able to reason through it, and can they express a choice, and is it consistent? And so we are planning to use a capacity instrument to map on the neuropsych testing to see which of the domains from the neuropsych testing really inform the capacity domains to really help us map what areas do we really need to make adaptations for. And then we also have prior studies showing that patients with MCI do experience greater decisional conflict, and that goes along with what I have seen clinically, and they have more decision regret than their healthy counterparts. And so again, this is a population that might have even more benefit from decision aids. So again, this is part of my K76. So the goal is to examine the approach for decision-making for patients with mild cognitive impairment, and just to hear from them. Did they think that cognitive impairment affected their ability to make this decision? And if so, how? We're using mixed methods, so we can map that onto their neuropsych testing and capacity testing as well. And then from that will inform adaptations that we make to our tool. So similar to the other study, we'll be performing interviews, undergoing alpha testing, and then we'll finally have a pilot trial once we have the decision aid. This time we are including care partners as part of it. Care partners are often involved in the decision making anyway, but then even more so for patients who do have MCI. And when I was looking at the literature, I thought that there's got to be something out there. Someone's got to have done something to help people with MCI make decisions. There's really not. There's only this one single study that looked at improving decision-making for entering a clinical trial, so trying to improve capacity. And what they made was this memory and organizational aid. And you can see on the right, the left column is what their standard informed consent would be. And then the right column is what the intervention group got. So they just call this their organizational aid. So a shorter summary, simpler, plainer language. And they thought this would act as a cognitive prosthetic for patients. And this was patients with mild and moderate Alzheimer's disease. And they did show that those who received the organizational aid did have improved decision-making capacity, and that was especially in understanding. And what we see in amnestic MCI and PD MCI is that it really is the understanding that is most affected. So based on this and then other literature and different types of MCI, looking at the cognitive domains and how those map onto capacity domains, we have some potential adaptations that we'll make. So as far as attention and working memory, that can really affect understanding, reasoning, being able to keep everything, with easy access. So here we might have short chunks, repeat things over, have visual and written summaries, just like they did in that other study. Executive function, going through the steps can be difficult. Thinking through one option and then moving to another option and being able to compare them can be difficult. So then having side-by-side comparisons that are more summaries can be helpful too. And then again, having those value clarification exercises so they can really think through, will this be a good decision for me? As far as memory, so providing take-home materials, because even people without mild cognitive impairment, we talk about a lot. And for them to go home, for us to expect them to go home and remember all that is just unreasonable. So making it, we can hand them something that they can take home, they can come back to the website, and then throughout the decision aid, repeat those key points. And then, a lot of patients with Parkinson's have trouble with verbal fluency is impaired, and so they can have word finding difficulty. So if we're asking values clarification questions or trying to get at values or do they understand the choice, you often don't want to ask open-ended questions because that can be hard for them to really get out what they're thinking about the decision. So then potentially having checklists or multiple choice questions or forced answer questions could be helpful. So based on this, at least what we're planning to do, we are almost done with AIM 1. We are adapting the decision aid currently, and over the summer it will go into a trial. We are planning to have a written summary. So that will be that one-page need to know. What are the key features that you need to know? And this will be informed by the interviews that we've done. We do also plan to have some short videos, 1 to 2 minutes from care partners, patients, so they can hear what went into their decision or what surgery was like, because that has been shown to help patients with lower health literacy, so potentially could help patients with mild cognitive impairment as well. Like I mentioned before, increased repetition of those key points, and then we're planning to continue to improve our value clarification exercises. And then just briefly, we're also looking at implementation of this decision aid as well. We're using the REAIM framework to look at those outcomes. And we're planning to enroll 60 patients with and without mild cognitive impairment because we want patients to be able to use this even if they don't have mild cognitive impairment. And then these are just some of the outcomes that we're looking at. So some of the big takeaways I want you to come away with from this is that DBS is appropriate for mid-stage Parkinson's. Say a lot of our patients think of it as a therapy of last resort. It's really good for mid-stage, and that is when they're going to have the most benefit. And then when we look at mild cognitive impairment, most people with mild cognitive impairment still have the capacity to make medical decisions, but they might have more difficulty. And prior studies have shown that that is especially in the understanding of the treatment options. We also know that decisional conflict can be higher in patients with MCI, and so decisional support tools that are tailored to those cognitive weakness can potentially improve decisional outcomes, and that's what we're hoping to do. And then here are just some acknowledgements. My mentors, co-Is, patient groups, funding, and then I can take any questions.
I just wanted to thank her for this great talk. We'll open the floor to questions. I think we've got Carrie right there. Oh, yeah.
Thank you. That was a great talk. I'm not a clinician, so I'm going to preface my questions this way. When you're looking at the factors on the sex disparity, particularly the clinician bias aspect, is there a sex difference in the clinician? We see this like on the cardiovascular side. And then another question is, are there sex differences in the presentation of symptoms so that maybe women are not being diagnosed because they don't meet the criteria that maybe were established for men?
Yeah, so great question. So in that Ontario study, they did look at the gender of the physician, and there wasn't actually a difference in who was referring for surgery, but I think there were only 2 female orthopedic surgeons, so hard to infer there. And we've looked at it with our own data, and again, we didn't see that women were more likely to refer women, but again, it was a small sample set, and we have turnover too, so then people are coming in and out. But it's definitely been shown in other fields. And as far as symptoms in other illnesses, I mean, it has been shown that women talk about symptoms differently, sometimes underplaying them. I'd say what I hear more often with Parkinson's is that, they'll describe the tremor or they describe the symptoms that they're having. And many times will tell me, they just told me it was anxiety, or it was menopause, or they're just told it's other symptoms and nothing else was done to further evaluate. So I'd say that's a very common story I hear with women.
Thank you for a great talk. I'm leveraging my question off of what you said earlier in the presentation regarding the efficacy of exercise training in mitigating Parkinson's symptoms. Has anybody looked at deep brain stimulation concomitantly with exercise training to see if it can augment the benefit of deep brain stimulation?
So we have some in our group who are looking at that. So maybe in a year or two, we'll be able to answer that question. But yeah, that's a great question.
Does the efficacy with that seem to be a product of advanced age, such that the younger you present the Parkinson's symptoms, the more beneficial the therapy could be, such that an older adult might be more resistant to the therapy?
So I think there are a lot of things that go into that. I mean, one, we actually know people who present at a younger age are more likely to have motor fluctuations, more likely to have dyskinesia, so potentially more likely to get DBS. I think what can help with exercise is that if you get DBS, then you might be more able to exercise. So that might be what the signal that we're seeing is in work that has been done. It does show that people after DBS potentially, again, it's not necessarily a factor of the DBS, but potentially slowing progression, but might be because they're able to exercise more. And that is one of the goals of therapy. I don't think I mentioned it before, but we want people to be able to exercise. We want to titrate medications and other therapies to that function.
I've got a decision aid question. So if you are making a decision aid or a consent form more approachable for people with mild cognitive impairment, obviously you describe some of the techniques that might help. How much of the lift is just increasing readability? Like if you had it go through an accessibility checker or someone looking for reading level, how much of the effort is really just making it more approachable to everyone?
Yeah, so I think that is definitely part of it. I think another part is there are just so many elements we have to include in an informed consent. And so then pulling out the key elements and having a summary that then people aren't getting lost in the weeds, but can come back to that. But certainly we do want to make sure it is readable at like a 6th grade level and comprehensible to everyone.
I have 2 questions. One was the 9% of folks with Parkinson's see a movement disorder specialist. So I wonder about the access issues and who is finally getting to you. That's one. And then 2 is the decision aids seem to focus on the procedure. And are there things people need to worry about in terms of just maintenance of the device and battery life? And at end of life, is it like a defibrillator where we need to turn it off? Or do we worry about things further downstream?
Yes. So one who is getting to us, I mean, movement disorder neurologists tend to be in academic settings in urban areas. It does tend to be people who are higher educated, live more urban, and have higher incomes. So there's definitely a disparity in who gets to us. And as far as knowing what to expect with DBS long term, there's definitely maintenance. So some devices now are rechargeable and can last 15 years without having to replace them. Are non-rechargeable, some only last 2-3 years. They're supposed to last up to 5. So then you're continuing to get battery replacements. Patients have to know to keep an eye on that because if the battery dies, then symptoms will all return. And then right after they get it placed, about a month later, they're coming back for multiple programming visits, but then we continue to see them over time because the disease will progress. So we're making changes to programming. It can stay on. It's not necessarily like a defibrillator. It's not going to hurt them, if they're actively dying. And we do know that even 20 years after DBS is placed, while you might not see it really helping with slowness or stiffness, it actually really helps with swallowing. People who had it turned off had worsening dysphagia. So people will typically leave it on for symptom management.
Really interesting talk. Thanks, Dr. Fullard. My questions around the, I don't know if the right word's like cognitive biases or the like cognitive thought processes that women had around decisional, like difficulty making decisions that men didn't express in the same way. Have there been, is that true in other fields, I guess, or is that specific to your work, or maybe you're the only one who's looked at it? And then have people looked at pairing like decision aids with like behavioral health visits to help explore that individual's cognitive biases and help them work through that?
Yeah, so I haven't seen any other work specifically looking at how women are weighing those risks and kind of not thinking about them applying to them. But that's a really great point. We do have a lot of our patients considering DBS see our neuropalliative team, so we could certainly bring that element in of just discussing that to make them feel more confident and not just saying, I'm just not going to think about the risk, but really, how do I think about how this applies to me and how do I move forward? That's a great idea.
I think that's time, but thank you so much for a really great talk.
Thank you.